Okay, well, let's continue on then. So just briefly to talk about some other things that can affect the cord. This is another one that we'd see quite often, and this is usually pretty obvious. Someone that's had significant trauma, motorcycle accident, something like that, sometimes sports related or diving into a shallow pool, something like that. And so there are certain areas of the cord that tend to be more susceptible to damage in that circumstance. So the key thing here is it's areas of mobility around areas of stability. And in the spinal cord, those are at the atlantoaxial joint, low cervical cord, thoracolumbar, and lumbosacral regions. So those just would be a little bit more common. And so this just depends on how much damage there is. If we have just a complete destruction of that level of the cord, then the patient's going to be paralyzed below the level of the lesion and won't be able to feel below the level of the lesion. But sometimes that can be just a hemicord, and it looks like a Brown-Séquard syndrome. Sometimes it can be rather mild. So again, it just will depend quite a bit on how bad the damage was. And usually for these cases, we give very high-dose steroids to try to take down inflammation around the cord. And occasionally, if we have something structural, okay, like as part of the trauma, maybe a disc fragment broke off and is also pushing on the cord, then we may want to remove that. Okay, so here would be a pretty obvious lower cervical cord lesion. Okay, so we can see how this is abnormally kinked here. This is just a lot of tissue swelling here in the posterior neck area from the trauma. Okay, now if you have a young individual that comes in just kind of spontaneously with what looks like a spinal cord syndrome, it's almost always transverse myelitis. And almost all of these are due to multiple sclerosis, which we'll get to at the end of this lecture. Okay, so these are not traumatic, and it's due to inflammation in the spinal cord. Okay, these tend to occur most likely in the thoracic cord. So I'll come back in a little bit, explain the pathophysiology of MS and why this happens. But these tend to be thoracic cord. So MS, I think I mentioned last year, is mainly a condition of young individuals. Okay, so we have someone 25 coming in, that has weakness, maybe from the waist down, and it wasn't related to trauma, then you should right away be thinking transverse myelitis, multiple sclerosis. This could be the initial event that indicates the patient has MS. So this usually happens pretty quickly, like within a day, someone is in the emergency room because of leg weakness, typically. So major presentation is spastic leg weakness, upper motor neuron finding. So if we just say the inflammation is at T4, okay, well, they're going to have sensory complaints and weakness below that lesion. Now, here's something that you should know about. It can happen with any spinal cord condition, but it's called spinal cord shock or just spinal shock. And this is a phenomenon where we have kind of an acute spinal cord pathology. And what happens is that transiently, so even though we're affecting all these upper motor neuron pathways in the spinal cord, but briefly, maybe just for a few hours, maybe for a day, you can actually lose reflexes. Okay, so you have this patient who comes in saying they're weak, from the belly button down or whatever, and the legs are weak, and you get out your reflex hammer and you think, okay, this has to be spinal cord. I'm going to find all these brisk reflexes, and you may not get them at all. Okay, and the mechanism for this here is not that well understood, but what usually happens is you come back then a few hours later and check the reflexes, and now you're getting them. And you come back a few hours later, and now they're very brisk, and now you're getting clonus and other upper motor neuron findings. So just to be aware of that this phenomenon of spinal cord shock, which doesn't last very long, but it can confuse you, especially if you're an emergency room doctor. Okay, now kind of a classic thing of transverse myelitis is that patients will often say at the level of the lesion, they have a tight band feeling. So if the demyelination inflammation's at T4, it's going to be like something tight right around the nipple area, or umbilicus, maybe around a T10 demyelination would cause a tight feeling right there. And we think that is from these crossing pain and temperature fibers right here. So of course we've got crossing pain and temperature fibers over here as well. So at the area where we have the inflammation, the distortion of those pain and temperature fibers creates that kind of tight, uncomfortable feeling right at the level of the lesion. Okay, and remember, any spinal cord syndrome, we get bowel and bladder dysfunction. So these patients often come in, they can't empty their bladder, and that's a significant part of it. Okay, so again, we'll come back to this here, hopefully, at the end of the lecture. Okay, our second to the last lecture in this course is neurologic complications of HIV. Okay, so I'm not going to say much about this for now, but just to recognize this is fairly common. 20% of patients with AIDS will have this, and it's the spinal cord. It's sometimes called the vacuolar myopathy because we get these kind of just cystic, fluid-filled spaces that usually are in the cervical spinal cord. Okay, so if we have an HIV patient who presents with what looks like a lesion in the cervical spinal cord clinically, then that could just be a manifestation of usually an advanced case here of HIV. Okay, this one is really important though that you get from this lecture. If we have really a stroke that affects the anterior portion of the spinal cord, and most often this is in the vascular territory of the artery of Adam Kavitz, okay, which we talked about last year, which supplies the mid-thoracic spinal cord. It's kind of a watershed area. It supplies the lower cord, thoracic cord, so we tend to get a stroke above that, like in the mid-thoracic area. And so it's just as a slightly susceptible area from a vascular perspective, and so these patients can have a stroke in this part of the cord. This will often happen during surgery of the abdominal aorta, okay, and especially if there's low blood pressure during the surgery. And so we have then ischemia of this anterior half of the cord. And so you just need to remember, we're trying to use these three pathways as our classic examples of anything that happens in the spinal cord. So the cortical spinal tract and spinal thalamic tract are in the anterior half of the cord, right? And so these patients, here I put the lesion way up here, but maybe it's going to be more in this area, they're going to lose pain and temperature, here in green, below the level of the lesion, and they're going to have weakness and upper motor neuron findings below the level of the lesion. The key thing is the posterior cord is not affected. Okay, so you get out your vibrating tuning fork and you put it on the big toe and it's normal. You check proprioception. They can perfectly tell whether the toe is being moved, but they don't have any pain and temperature sensation. Okay, so we know that has to be just the anterior portion of the cord that's affected. So this can happen, as I said, related to surgery that might affect the artery of Adam Kavitz, and it certainly would be more likely in any patient that has vascular risk factors. And the two biggest, of course, are diabetes and hypertension. Okay, so from last year we talked about the vascular supply of the spinal cord. And so here are nerve roots, okay, a sensory and a motor nerve root. And so there are these radicular arteries that travel along with each nerve root, okay, all 31 segments all the way down. Okay, but it turns out that only about 7 or 8 of the radicular arteries are really significant in terms of actually supplying the spinal cord. Okay, and so these kind of boost the blood supply of the spinal cord all the way down. And so a major one here is the artery of Adam Kavitz. Okay, and it's contributing to the supply then of the anterior spinal artery. Okay, and so again, if this is affected, maybe as part of abdominal aortic, maybe the patient has an aneurysm, and we're losing this contribution here from the artery of Adam Kavitz to the anterior spinal artery, then this patient would be at risk for having a stroke of the anterior portion of the cord. Okay, so again, that's what happens in an anterior spinal artery stroke. Okay, 3 things I think, well, 2 really, that you should know in terms of how do you treat spasticity. So you have someone that's had a spinal cord injury, and often the chronic complication of that is the legs are stiff and spastic, and it affects their ability to walk and move. So one of the medications that's used very commonly is baclofen. Okay, and baclofen stimulates the GABA A receptors. So when we talked about GABA last year in neurotransmitters, I said it's the A receptor that's really important because we can manipulate that through a lot of medications. So here is just the GABA binding here to the GABA A receptor, but it also has sites that bind to other medications, and unfortunately it's not shown here, but baclofen does have a binding site on the GABA A receptor. So you know GABA is an inhibitory neurotransmitter. Spasticity is a condition where we have kind of a excessive, too much excitation of upper motor neuron pathways. So having more inhibition is actually helpful. Okay, so you stimulate GABA A receptors and it just tends to, and this is usually not dramatic, but it tends to quiet down the overactive upper motor neuron pathways. So we can give this orally, and it can also be delivered right into the CSF, and that's called an intrathecal pump, where you try to deliver it, more get it right to where it is needed. Okay, and so this can be sometimes quite effective for patients, and their walking is improved a lot. Okay, another category of medications, similar mechanism here, benzodiazepines work for this as well. So diazepam, otherwise known as Valium, helps for spasticity. Okay, here's the binding site on the GABA A receptor. But these medications just wipe you out, right? So practically, you may put a patient on this and they just feel groggy and sleepy. So we prefer to use baclofen. Okay, and we actually may have the most evidence for using botulinum toxin for spasticity. And so I have a patient, for example, at the VA who 20 years ago accidentally shot himself in the head with a nail gun. And he brought in the newspaper article from 20 years ago with a picture of the nail, going right into his brain. And so he has some spasticity on the opposite side of the body. And his arm is always in this position. Okay? And especially when he walks, he just finds that really annoying that his arm keeps doing this. And so I inject botulinum toxin into the two elbow flexors, the biceps and the brachioradialis. Okay, so remember that's going to affect snare proteins. You don't release acetylcholine, and so therefore the muscles just relax a little bit. He's able to, his arm straightens out. Okay, so this is often kind of a rewarding thing that we do with botulinum toxin injections. Tends to be pretty effective. Okay, now there are certain conditions in the spinal cord that tend to knock out lower motor neurons. Polio would be our classic example from 60 plus years ago. Polio kind of looks a lot like Guillain-Barré in the presentation. Patients come in just diffusely weak. The problem is in anterior horn cells. Okay, so we knock out anterior horn cells, and so those are lower motor neurons. So this would be a floppy, flaccid paralysis, not a stiff, spastic weakness, but a flaccid paralysis. Okay, and so the weakness, it just depends on which anterior horn cells are knocked out. So it tends to be the legs predominantly. Sometimes it can even be more anterior horn cells on one half of the cord, and it can even look like one side of the body. Okay, anytime we knock out anterior horn cells, patients tend to have a lot of cramps. So when they try to use the muscle, they just have a kind of a crampy feeling. And remember, fasciculations are the hallmark feature of an anterior horn cell disease. So it's very unlikely you're ever going to see a new case of polio. Okay, but you will see individuals that had polio many decades ago and look at the muscles. Okay, if we're looking at the quadriceps, then you look for a little rippling in the muscle. So fasciculations can be a chronic, lifelong issue in someone with polio. I shouldn't say issue because it really doesn't annoy patients at all. They're aware of it, but just like you're aware of the eyelid twitch. It's annoying, but it's not really disabling. So remember, the lesion is anterior horn cells, so sensation is going to be entirely normal in someone with polio. Okay, I really admire here the discovery here, and that Dr. Salk did not want to patent here the vaccine. And it seems like everything is getting patented recently, which is really annoying. The 30-point mental status examination, someone put a patent on that. So now we have to pay for it if we want to use it. And those things are just dumb. So he was not a fan of that. So just if you see someone that had polio, trying to get the story. So usually the polio virus, most people are not symptomatic. 5 to 10% have minor symptoms. So here it's just the 0.1% of those that are exposed that actually get a meningitis. And then the effect of that can be destruction of anterior horn cells. Okay, so how does it get there? Well, it crosses the blood-brain barrier and it travels back up the axon, retrograde axonal transport all the way to the anterior horn cell where it knocks it out. Okay, these can even destroy some of the lower motor neurons in the medulla, like the hypoglossal nucleus. That's just an anterior horn cell, really. We give it a new name because it supplies the tongue, or the nucleus ambiguus. So rarely these patients can have some talking and swallowing difficulties. But it's usually predominantly the spinal cord, anterior horn cells. Okay, so this is easy to diagnose. You have to get spinal fluid, and you do some PCR testing. There was a case of polio and someone from Mexico not immunized here at Loma Linda maybe 3-4 years ago, but that's the only one I've heard of in a long time. Okay, the biggest concern in someone with polio is that you can have respiratory failure from knockout of anterior horn cells that would be important for breathing. Okay, so the lesion is here, anterior horn cells. Again, we're going to get Wallerian degeneration. And so we're going to have a lot of atrophy, fasciculations, and weakness in the distribution of those anterior horn cells that are affected. So in this patient, let's just say it's lumbosacral anterior horn cells that are affected. So it's going to be predominantly the legs where we'll have weakness. Okay, West Nile virus is kind of the modern day polio. It's very similar to polio. Okay, and so just to look at the number of cases, so this is transmitted by mosquito bites. So, we tend to see this around this time of year. So late summer, early fall. And you can see that these cases that would be neuroinvasive were pretty rare, 20 years ago. And they're, they fluctuate quite a bit, but overall the trend has been of increased number. So there's an incubation period. And so after the mosquito bite, so 25% may get what's called the West Nile fever. Patients may just say they had the flu. They were in bed with a fever and a headache. Maybe they had a rash. Okay, and then they recover. Like polio, it's actually uncommon. Less than 1% actually have any neurologic involvement. And so most often this is a meningoencephalitis. So fever, headache, neck stiffness. Remember the difference between a meningitis and encephalitis. In encephalitis, the brain is involved in inflammation. So there the patient may have seizures or weakness or whatever area of the brain is affected. If the language area is affected, they may have an aphasia. So an encephalitis would be much more severe, of course. Okay, but of the neurologic involvement, it's really only 8% that have an acute flaccid paralysis. But it's the same thing like polio. Anterior horn cells are knocked out. Okay, so I've seen a number of cases of this, and it tends to be pretty severe. I mean, the limb that's affected will atrophy pretty quickly, and it's quite disabling for the individuals that have this. So most of the questions I think you're most likely to be asked on boards about West Nile are actually this, even though it's not that common. So we want to think of West Nile in terms of destruction of anterior horn cells. Okay, so if we think about it, again, we can do this on the serum and the CSF. CSF is probably a little better. So we look for the West Nile specific antibodies, IgG, IgM. Okay, when you do a lumbar puncture, it's going to look like a meningitis. Okay, this doesn't tell you the diagnosis, but yeah, you thought the patient had a meningitis. Here we confirm it with this, but we need to do the more specific testing here to confirm that it's West Nile that's the one that's doing it. Okay, if you do an MRI of the brain, if the patient had encephalitis, then you're going to see some areas of the brain light up, depending on where the inflammation is. Okay, so now we move on to ALS, which is our hallmark condition here where we have upper and lower motor neurons that are affected. And I put ALS in the spinal cord lecture, even though, you know, it's not just the spinal cord that's affected. This is just kind of a good time to talk about it. So we talked a little bit about this condition last year, and I may have told you that I think this is the last baseball card of Lou Gehrig, and neurologists have noted that maybe he had some atrophy of his hand here, and his statistics, batting average, plummeted rapidly here as he was developing symptoms. So the key thing with ALS is that you get a double hit on upper and lower motor neurons. That's why the weakness is so rapidly progressive. So the two upper motor neuron pathways I would know about for ALS that degenerate are the cortical spinal tract and the cortical bulbar tract. Okay. ALS is, I think, better called motor neuron disease. If we want a better, more encompassing term, call it motor neuron disease, because it's the neurons that are affected. Okay, so it's not really the pathway itself that is damaged, it's the neurons up in the cortex that are destroyed, and then you get Wallerian degeneration and the whole pathway dies. So the cortical spinal tract then will give the patient upper motor neuron weakness. Cortical bulbar tract degeneration. So now we lose the connection between the cortex and the brainstem. And so that is very important for talking and swallowing. And so this is part of what's known as pseudobulbar palsy. Okay, and we're going to list a number of conditions from here on in the course that cause pseudobulbar palsy. So here's the first one. Okay, and pseudobulbar palsy is dysarthria, dysphagia. Okay, and interestingly, they have something called emotional incontinence. And it's not a very flattering term, but it refers to just a great difficulty controlling your emotions. And it's not a sad feeling. Patients will say, they watch something on TV, it's not that sad, and they just can't stop crying. Okay, it is a reflex kind of a thing. Or sometimes something happens, it's not that funny, and they can't stop giggling. Okay, and so if a patient is having also dysarthria and dysphagia, then that is pseudobulbar palsy. And so the pathway you want to associate with that is the cortical bulbar tract. Okay, so in ALS, the upper motor neurons, cortical spinal tract, cortical bulbar tract are affected, and also the lower motor neurons are affected in the spinal cord and brainstem. Okay, so in the spinal cord, it's the anterior horn cells that degenerate. So that will give a patient lower motor neuron weakness, atrophy, and fasciculations. Okay, but if we just say if an arm is being affected, you know, it's so rapidly progressive because the patient is not only losing cortical spinal tract, but they're also losing the anterior horn cells that are supplying the muscle. Okay, if brainstem lower motor neurons are affected, and interestingly in ALS, it's always the lower part of the brainstem that's affected, the medulla. So the pons in the midbrain is relatively spared in ALS. So the two areas I would remember in ALS are the nucleus ambiguus and the hypoglossal nucleus. Okay, so if you knock out the hypoglossal nucleus, then the tongue is going to atrophy. Okay, and if you just look at the tongue, you'll see fasciculations in the tongue. And so that's going to affect the patient's ability to talk and swallow. If you knock out the nucleus ambiguus, that's the motor nucleus for 9 and 10. So now patients have another reason they can't talk and swallow, right? So they tend to have a fairly significant dysarthria and dysphagia, both from pseudobulbar palsy, that's upper motor neuron, okay, but also from lower motor neuron involvement for talking and swallowing, and we call that bulbar palsy. Okay, and it tends to start with one or the other. So if it starts initially with more upper motor neuron, then the patient will have more pseudobulbar palsy, and then later on, these lower motor neurons will be affected, and now the tongue atrophies, and they have bulbar palsy on top of it. Okay, so again, it's a double hit that is the severe thing. Okay, so let me just show you. So quite a lot of videos here. I can't show you all of them, but this one is just quick. So here's a patient that has tongue fasciculations. Okay, so the tongue is kind of quivering. Those are all fasciculations, and you can see there's atrophy of the tongue as well. Now, just be very careful. If you ask anyone to stick their tongue out, the tongue quivers a little bit. Okay, so you could easily call fasciculations in everyone. But this, you know, the tongue is relaxed, and you can see it's kind of shriveled up. Okay, and then I don't think I showed you this video last year, but even if I did, it's worth watching again. Here's a patient that has ALS.
Have you repeat a little bit of the history that you just told me? You said about 1.5 years ago that left hand just kind of gradually stopped working well.
Right.
Describe what that was like.
At first I noticed a loss of muscle control, motor control. My writing got to be, instead of precise, it started to get wavering with me. Mm-hmm. And the more I tried to tell the hand what to do, the more that it quit functioning.
Nice.
So in his case, it just tended to start out with the hand. Just as likely it could start with the foot. So foot drop would be another common initial presentation of ALS. And if you just kind of observe this patient, you may see some fasciculations here. It's an older video, but eventually you focus in on them and it's pretty obvious.
And it's just kind of gradually
got
worse and worse.
Sure.
Mm-hmm. Now, you haven't really had any lack of sensation in that hand or in the arm at all. You can feel well.
Right, I can feel, of course, sharp objects, hot, cold, texture. Mm-hmm. There's been no sensory loss that I can detect over 1.5 years.
But you noticed that you've just been losing the muscles in that arm. They seem to be kind of withering away.
Kind of going away, yes.
Okay.
A bench.
Now, you haven't had symptoms anywhere else except that you have muscle cramps now that are kind of in the legs and in both arms.
Right.
Twitches that are kind of all over.
Definitely, all over.
Yeah, and those aren't really painful, but you said they can kind of wake you up at night sometimes just because you're aware of them.
At first, they were not violent enough to disturb my rest. Mm-hmm. But here within the last year, they woke me up at night.
Okay, good. So let me just check a couple of things. You haven't had any swallowing or talking problem at all?
Not until I got here. What are you talking about?
You just leave it there.
Where's the allergy section?
Okay, let me just check a little bit with your strength. Let me have you fold the elbows up like this and push up hard. Okay. Pull towards you. That's pretty good. Now you're left-handed, aren't you?
Was.
Okay. Pull towards you. Okay, so that arm is weak. Now give me a hard push away here. Push me hard away here. Okay. Try to hold the hands out straight. And then over here. We have a hard time doing that here. Okay, let's go ahead and pause that.
Now hopefully you can see the twitches there, the shoulder, chest, lots of fasciculations here on the chest. And the biceps.
Some of these. No kidding, virtually foolproof. Yeah, almost.
Okay, I'm just noticing the difference here in the muscle bulk in the two hands. And you've noticed that in that left hand particularly, there's been some muscle loss. Right here in this space, the first dorsal interosseous, really is a significant amount of atrophy right there. Okay. Now, you feel the pinprick sharply there? Okay. And then how about down here?
Yes.
Okay, feels sharp like a pin.
So again, it's motor neuron disease. Sensory nerves are fine. No problem.
Yes. And let me just check a few reflexes. Okay, I'm going to go over those here.
Okay, so there we see some upper motor neuron wrist reflexes in the right arm.
Curl the fingers in just a tiny bit there.
Okay, this is an upper motor neuron finding you don't need to know about, but if you tap the fingers and the whole arm, you even get a elbow flexion, that's an abnormal spread of reflexes. It's an upper motor neuron finding, but don't worry about that.
Spread of reflexes. Let me check over here.
Now, I can't get reflexes very much in the left arm, and that's just because there's so much atrophy, right? It's predominantly lower motor neuron in the left arm. This is what you see in ALS patients, kind of a patchy mixture of upper and lower motor neuron findings.
That's this here in this left arm, although it's still present there. Okay, good. Let me just check a little bit here in the legs. Sorry about that.
Okay, let's stop that. Okay, so the presentation of ALS, it tends to be initially asymmetrical. So his presentation was hand weakness initially. So that would be about a third of cases. Another third, it could just start in the leg. So foot drop would be, as I said, another really typical presentation of ALS. Okay, and about 20% it's bulbar. So either pseudo-bulbar palsy or bulbar palsy. So we always worry about this. Someone comes in and they're having some slurred speech, difficulty swallowing. Well, that could turn out to be ALS. I mean, there's a big differential, but that would be another presentation. So what is preserved? Well, the areas above the medulla tend to be preserved. So by and large, eye movements are normal. Okay, it just tends to be kind of the, again, just think of the mouth and talking, swallowing, tongue movements are affected. Okay, cognitive function, with one exception, which I'll talk about, is usually normal. Now later on there can be some cognitive function, but early on you don't tend to see much involved there. Sensory nerves are pretty normal, and interestingly bowel and bladder function is normal. So there are anterior horn cells here. Obviously they're important for the bladder. It's called Onuf's nucleus, and it is a mystery why these anterior horn cells are preserved. There are some ideas. Okay, but these patients tend to have preserved function there. So again, if we think of this motor neuron disease, the problem is up here with the upper motor neurons, and then we get Wallerian degeneration. And the problem is here with the lower motor neurons, and we get Wallerian degeneration. Okay, so I had the student draw it this way, hopefully to help you remember here, that's kind of like from the mouth down. That's affected. Now it's in a very end stage advanced ALS patient. You can have eye movements and, you know, motor neurons that are affected can be involved there, but that would typically be as a very late stage. Okay, here we're looking at an MRI scan, and this is the cortical spinal tract. So we can actually see that Wallerian degeneration on an MRI scan. You can visualize that pathway. Again, the problem is up here with the motor neurons, but this is the Wallerian degeneration. All right, so some ideas about ALS. It's not real common, 2 per 100,000, a little bit higher in men. Interestingly, there are no more than 10% of cases that are familial, so there's a family history. Most of those are autosomal dominant, and it's kind of interesting that those tend to be younger individuals than our sporadic cases, which are a bit older. 55 to 75 is kind of a common range there. There's a little bit of controversy over this because we think some elderly individuals, you know, someone's in their 80s or in a nursing home, and well, grandpa just got kind of weak in the last few months of his life. And so it's thought that we may be missing some cases of ALS in the elderly, just attributed maybe to age or something. So again, it's pretty rapidly progressive condition. So death is usually within 3 to 4 years of the onset of symptoms. So there's been a lot about genetics, and there are just 2 that I think are worthwhile knowing. This was the first gene discovered as a contributor to ALS, discovered in 1993, and so some autosomal dominant cases are due to superoxide dismutase mutations, and it's felt that the mutant protein here may accumulate in motor neurons and have a destructive effect. But this is actually a pretty small, I mean, there's so many genetic lesions that have now been discovered, and this only makes up 10% of familial ALS. And remember, familial ALS is no more than 10% of all ALS, so really only 1% of ALS cases then are related to superoxide dismutase abnormalities. But I would still remember that because people like to talk about it. It's the first one discovered. Here is, I think, the more important one, and I'm sorry it wasn't given a name that is, rolls off the tongue here, but C9ORF72 mutations, okay, is more important. There are these repeat expansions, okay, and this makes up almost half of familial ALS, and even a fair number of sporadic cases. So there's no family history, okay, but 5 to 8% of the sporadic cases may be a new mutation. Yes? What causes the other 90%? Yeah, good question. That's been a lot of the mystery in ALS. Now, there have been some really good discoveries here, I would say, just in the last couple of years. And if some of you have a chance to work with Dr. Rosenfeld in the third year, he's our ALS specialist here at Loma Linda, and I would say he's really on the cutting edge of some of those new ideas about ALS. But I'm not going to go into it more than a little bit here on the genetics of some of these. And the reason I want you to know this one is because this is also associated with frontotemporal dementia. So when we get to the dementia lecture, we'll say there is a relationship between frontotemporal dementia and ALS. Only 10% of ALS patients have a frontotemporal dementia, but even though I told you cognitive function is pretty normal early on, up to 50% may at some point have some cognitive and behavioral involvement. And so this specific mutation is kind of a link for understanding that overlap sometime with the brain being affected. So I would know those two. Sorry, I put this in your handout, but I want to ask you about TDP43, but that's another one. All right, so ALS tends to have, it's our classic condition of something where there are upper and lower motor neuron findings, but like everything in neurology and medicine, there's a spectrum. So some patients may have only lower motor neuron involvement, and the upper motor neurons are never affected, and we call that progressive muscular atrophy. Some patients may only have upper motor neuron findings. I have 2 patients at the VA with this, and it's pretty rare, and this is known as primary lateral sclerosis. This tends to have a fairly good prognosis, at least compared to ALS. So they only have upper motor neuron findings, and they never get any of the atrophy or fasciculations. Okay. ALS has been very frustrating compared to so many other things in neurology that are now so treatable. I did my fellowship in ALS, almost 20 years ago, and boy, we thought we were right on the cusp, and still don't have an intervention that I would say is meaningful in terms of effectiveness. So Riluzole is an FDA-approved medication, and this is one you're often asked about, again, because the mechanism is known. And this is against glutamate receptors, specifically NMDA. Okay, that's one part of the mechanism. And so just kind of think glutamate as an excitatory neurotransmitter. So the idea was maybe glutamate is somehow toxic to these large motor neurons. And so you can see that even in our most optimistic study, we prolong survival by only about 2 to 3 months. So this is not a huge intervention. So remember the NMDA receptor, and so we're going to come back to this when we talk about stroke and the mechanism of cell death in stroke, which involves NMDA receptors. But again, that's the mechanism here of Riluzole, is trying to prevent cell death through interaction with this receptor. Now there was another FDA-approved medication, very recent, but you would never be asked that on boards, and it's no more effective than Riluzole, unfortunately. Okay, so let me just stop there, see if you have any questions about ALS before we go on. Yep. Does Riluzole just help with the upper motor neuron? Well, patients don't really notice anything. Like, I've never had a patient come back and say they're a lot better on the Riluzole. We only know that when you look at in large populations, that the death is slowed just a little bit in the patients that are on Riluzole. And it probably is more by its effect on the brain and the upper motor neurons. That's probably true. So there are some spinal cord conditions that tend to affect mainly sensory pathways. So our classic example here is syringomyelia, which is a central cavitation of the spinal cord. So you need to associate syringomyelia with the crossing spinothalamic tract here. That's the key thing. So who gets syringomyelia? Most of these are related to Arnold Chiari malformation, which Dr. Deich is going to explain to you. But in a nutshell, Arnold Chiari malformation is due to low-lying cerebellar tonsils that hang down into the foramen magnum. Okay, so if we do an MRI scan, we can actually see this. Okay, and the effect of this tends to cause a central cavitation in the spinal cord. Okay, why does that happen? Well, it may be cerebral spinal fluid, when it's produced in the choroid plexus, it gets produced in kind of a pulsatile manner. And so if we have this abnormality right here, it's felt that as that's being produced, somehow it's almost like pressure is being pushed down on this area, which causes the central part of the cord here to cavitate. Okay, so if you find a syrinx, you always want to do a brain scan and look and see if the patient has this Arnold Chiari malformation. Okay, so the lesion tends to start here in the center of the cord and they grow out. So always the first pathway that's affected is right where the spinothalamic fibers cross. Okay, so if we have a lesion here that starts out at C5, then we're going to affect pain and temperature sensation in a bilateral C5 dermatomal distribution. And so the initial complaint of the patient would be, even though I'm just showing you one arm here on the picture, it's going to be perfectly symmetrical in both arms in C5. Okay, now as the syrinx extends down, now it's growing down to C7. Okay, now we're going to affect pain and temperature. Again, perfectly symmetrical, both arms, C5 to C7 dermatome. So now it's going to be larger. Okay, and these syringomyelia is usually in the cervical cord, almost always, and so it's usually with this arm involvement. So this is one case. If you've got someone with arm numbness, you need to get a safety pin out and really map out, you know, what's the dermatomal distribution of this. Okay, occasionally the syrinx can grow up into the medulla, and there we use the term syringobulbia. Remember, bulbar is talking and swallowing. So if you affect the medulla, then these patients can have some dysarthria, dysphagia. I've never seen that, okay, but the arm involvement here is, I think, what's important. Okay, and I've had so many emails from students over the years thanking me for this, so I'm going to tell you, like I tell all students, boards are really in a rut asking about syringomyelia. It's always the same vignette, and it's someone cooking and they're burning their hands and they're not aware of it. Okay, because this patient has lost pain and temperature from syringomyelia. So he's out in a barbecue and hand is getting burned, but because of the loss of temperature sensation, had a severe burn, okay, and then but only was aware of it by looking at his hand, not because he was feeling anything. Okay, so when you get that vignette, someone burns their hand cooking, it's syringomyelia is the right answer. Okay, other things that can affect the center of the cord, we can have, as I said, tumors. And so the one I'm going to mention here are the intramedullary tumors. Remember, those are ependymomas and astrocytomas. So these also tend to grow in the center of the cord, but they spread out a bit differently than syringomyelia. They tend to grow out a little bit like this, okay? And they affect the spinothalamic tract initially. So here we've got a tumor that is growing out here at C5, and it's affecting the spinothalamic tract. Okay, and remember the columnar arrangement, which is that the sacral fibers are way out here. Okay, so in a spinal cord tumor, we get what's known as sacral sparing. Okay, where below the level of the lesion here, all the cervical, thoracic, and lumbar dermatomes will be affected, but the sacral dermatome will be spared. Okay, so you check sensation all over, and it's affected below the level of the lesion, but then way down in the sacral area, they can feel pain and temperature. Okay, so that could only be explained by something that is affecting this area. Okay, B12 deficiency. So while this would be really rare, okay, maybe make a good board question, but practically, I can't remember the last time I've seen this. B12 is just practical for real world, and certainly it would be high yield for boards. So B12 deficiency, otherwise known as subacute combined degeneration, tends to occur in older individuals, often related to pernicious anemia, which Dr. Werner will tell you about. And so these patients, because of the loss of these gastric parietal cells, don't absorb vitamin B12. Okay, and so the major manifestation, don't forget, is posterior column dysfunction. A lot of things are affected in B12 deficiency, or can be, but that's usually what brings a patient in, and that's your most dramatic exam finding. So the usual complaint is gait instability from loss of proprioception. Okay, and what should stand out more than anything else on your exam is a severe loss of vibration and proprioception. Okay, so they're falling. Okay, but we call this subacute combined because, that's not the only thing affected. Lots of other areas are affected. The corticospinal tract is often affected. So these patients will have some upper motor neuron findings. They've got a Babinski, or they've got some clonus, or maybe a little spastic weakness. Okay, and the small sensory nerve fibers are affected, so they also have a peripheral neuropathy. They've got stocking glove sensory symptoms. Okay, so if you haven't heard of B12 deficiency, this will be very frustrating when you see a patient with this, because you can't localize the lesion. That's always what we want to do. That's the satisfying part of neurology, right? We can pinpoint lateral medulla, there it is. And you can't do that with B12 deficiency because you've got kind of scattered lesions all over the place. So the red flag for you, anytime, let's say we see someone with a severe loss of vibration and proprioception, B12 should come to your mind. Okay, could be something else, but let's at least rule out B12 deficiency. Now it makes it easier then if, oh yeah, we've also got something upper motor neuron, and they've also got numb toes and fingers, and if you remember it, then you can be more strongly suggestive the patient has B12 deficiency. If we do an MRI of the spine, okay, now this should all appear dark, the spinal cord all the way down. So these are the posterior columns right here. Can you see it's bright? Okay, so that is actually demyelination of the posterior columns. Okay, so here's a picture of B12 deficiency. So it's posterior columns, but it's also corticospinal tract. And so patients come in falling because they don't know where their feet are in space. And they may also fall because they've got a little spasticity from the corticospinal tract involvement. Okay, so there can be other neurologic things. The optic nerve can even be affected in B12 deficiency, and patients can have visual loss. B12 is important for just how your brain works, for memory and thinking. And so whenever we have a patient coming in with dementia, we check a B12 level. Okay, it's not very often we find that's the cause of the memory loss, but you'd hate to miss that. Okay, and it can even cause some altered taste sensation as well. Lots of non-neurologic things. Some patients can have just an irritation in the tongue. They feel like it's swollen. Hair loss and skin changes can happen. Patients may lose weight. And you will learn about a megaloblastic anemia, where actually the size of the red blood cells will increase in patients that have B12 deficiency. So a lot can happen, but this is one certainly that you'd want to make sure you really have down, because you're often asked about it. So practically, we check a B12 level, but what often happens is you look at the lab values and it will say normal is more than 200 is a normal B12 level. But oftentimes in the elderly, you'll get kind of borderline levels, and you're wondering, is this really significant or not? So actually the more helpful tests for B12 deficiency is to check for methylmalonic acid and homocysteine levels. Okay, these are very, very sensitive for symptomatic B12 deficiency. So they're very elevated. So if we get a level, let's say of 200, right on the border, and your methylmalonic acid and homocysteine levels are significantly elevated, then that suggests this is a symptomatic B12 deficiency, and we're going to treat this patient for B12 deficiency. Okay, so for years, we would give B12 injections, and recently it's been shown that if you just give a mega oral dose of vitamin B12, it can actually overcome even the absorptive deficiency. So we're usually just using a really high oral dose, although sometimes if we have a more severe case, we may give a patient B12 injections. Okay, so let's stop there, and I'm sorry I need to leave. I have a 9 o'clock and a 9:30 patient waiting because I wasn't aware I was giving this lecture, so I'm going to run for my car.